about general urology maybe as it changes as we get older. And the goal is education, you know, and it's really important now, I think, that patients have to be their own advocate. I go to the dentist and I don't know, do whatever you want, take out my teeth. I don't know what to do, but you can't do that with cancer. Now the other stuff, not going to kill you, that's okay. But really the job of the physician is when that patient leaves the clinic, all questions are answered. And if a family said, well, why is he doing this? I should be able to answer that. If you have a why question, I better have an answer, otherwise there's a problem. So please, if you have any questions, either write them down or whatever, but we want to make sure when you leave, whatever reason you came here, you got that answer, and I should be able to provide that for you, and if I can't, I'll find somebody who can. So, no, I grew up in Springfield. In fact, one of the talks I gave, this guy was here, and he was my barber at the men's room when I was in high school, so they moved from, I don't know, they're on Chatham Road now, but in any event. So we'll talk a little bit with female, and there's Dr. Arjman. With females, one of the more common problems as we get a little older is incontinence. And the difference with the anatomy is men, it's usually a prostate issue where the bladder contracts, but you can't get the urine past the resistance, which is the prostate. So guys, they go to the bathroom a lot because they're never emptying their bladder. You know, they want to empty, then you fill back up. Well, men with a big prostate, they just empty a little bit and they fill back up again, so they do this all day. Where women, there's no prostate, so there's no resistance. Men have too much resistance. Women have no resistance, especially after having children, that women can't keep the urine in their bladder. So they go to the bathroom all the time. And there's two types of incontinence, stress and urge. And a lot of times they can be mixed. So stress urinary incontinence is typically in women, and it's when you increase your abdominal pressure. That increases the pressure on the bladder, and that pressure is greater than the outlet resistance because there's nothing resisting it, and you leak. So anything that increases abdominal pressure, coughing, lifting, standing, doing any kind of grunting, anything like that, puts pressure on the bladder squeezes, but the outlet resistance is too weak, so you leak. So that's stress incontinence. Urge incontinence is where the bladder is hyperactive. So you got to go to the bathroom all the time. There's nothing in your bladder. It just feels like you have to go. So it's a nerve problem. How do you fix these? Well, stress urinary incontinence, they say do the Kegel exercises where you squeeze down. I'm not quite sure how much that helps. Bottom line, I tell patients, if it's bothering you, if it's not bothering you, don't do anything. It's a quality of life issue. And it's really difficult to define quality of life. Somebody may leak one pad, and that may be the worst thing in the world, and somebody else leaks 4 pads, and then, I'm okay with it. So stress urinary incontinence, it's essentially either live with it or surgery. And the surgery is fairly straightforward surgery, but those are the kind of the two extremes. And the mesh got a lot of bad press. They would put mesh in to kind of lift up the bladder, but then the mesh is a foreign body and would erode into the vagina, into the bladder, and that's kind of a bad thing. So there's a lot of lawsuits with that. But that's stress incontinence in women. The other part is urge. And urge, we got to go all the time. And that you give like Detrol, Ditropan. It's a medication that blocks the muscle receptors in the bladder. So that helps. So urge is not really a surgical cure therapy. It's medication. And stress is surgery. So sometimes somebody may come in and they may have both urge and stress incontinence. So you give them medication for urge, and hopefully that gets better, and then sometimes the stress incontinence can get better. If not, then you have to do surgery for the stress. The medications for urge incontinence, again, it blocks the muscle receptors in the bladder. Well, you have same receptors in your salivary glands and in the colon. So maybe 10% or so of patients can get dry mouth, and 10% or so can get bad constipation. And again, we're giving a drug, doctors are not very good at this, including myself, I'm sure. We're giving a drug to improve quality of life, but we may be hurting quality of life because of the medication we're giving you. So I tell patients, if it's not cancer, if the medication is worse than the problem, stop the medication, we'll try something else. And that kind of goes, get off topic a little bit, with cancer as well. We're all going to die. And let's say somebody's going to pass away in 2 months, 60 days. And we can give you a new drug that instead of 60 days, you die in 70 days. But those entire 70 days, you have terrible side effects. Is it worth it? I mean, seriously, is it worth it? So that 70 days is maybe your quality of life is miserable. And you don't want to do anything. You can't leave the house. But we improved your survival by a week. And there are drugs like that where we're improving survival 2 weeks to a month. And we have to question ourselves, are we treating the patient or are we treating the cancer? We can always treat somebody. We can always come up with something. But is it the right thing? And I hate prostate cancer because we're not very good at it, in my opinion. There hasn't been a great advancement on prostate cancer since 1945. We really haven't done, we had all these new drugs, but we've improved survival since 1945 by 4 months. 4 months, that's it. So it's a terrible disease. And again, as we talk about quality of life, with prostate cancer, they did a trial in Europe. And we didn't do it here. And they said if you have, well, there was one here too. If you have low-grade prostate cancer, meaning a PSA less than 10, Gleason 6. So Gleason was a pathologist, and he looked on the microscope, and they graded the tumors, 3, 4, and 5. So, and he looked at the two biggest populations or islands of cancer cells, and he said if it's 3 is low grade, 4 is intermediate, and 5 is high. But you get 2 scores. So you get 1 score and another. So you can have a 3 plus 3 or 4 plus 3, whatever. 6 is your lowest, right? Because you have a 3 and a 3. Then you get a 7, and then 8, 9, and 10. So low-risk prostate cancer is Gleason 6. Normal rectal exam, which most of the time they're found because the PSA is elevated. But for low-risk prostate cancer in Europe, you got an envelope. And it said either surgery or watchful waiting. We're not going to do anything. We're not going to ignore it. We're going to respect it. We're going to watch it. And we may have to redo a biopsy to make sure it's Gleason 6. End of the day, most important question, are you alive or are you dead from the cancer? If you died of a heart attack, that doesn't count. Because I could cure everybody. 80-year-old man, 85-year-old man with a terrible heart and prostate cancer, he'll never die of prostate cancer. So my drug didn't cure him. He just died of something else. So we got to be really careful when people say, oh, nobody died of prostate cancer. Yeah, but if they died of something else, that doesn't really count. So if that makes sense. So we got to look at prostate cancer death. And in that trial, if you had low-risk disease, no difference. Amazing, isn't it? No difference. If you're older than 65, no difference in survival. So why are we doing it? Good question. And then that goes, I looked at it last night. I'll get back to general urology. We don't even know if we should do PSA screening. PSA was developed, I don't know, Chang, I think was his name, late 80s, I believe, early 90s. PSA was developed to follow a patient to see if they have a recurrence. So you already have your prostate cancer, they radiated you, or they gave you hormones, or they took out your prostate. We couldn't really tell if it came back till you have bone pain, then you get a bone scan, it's symptomatic. So PSA was developed to get patients after whatever therapy they had to see, because if your prostate's gone, your PSA should be 0, right? Prostate cancer makes PSA, and normal prostate cells, benign. I have my PSA something, I hope it's low, but all males have a PSA. If your prostate's completely gone and all the cancer is gone, your PSA should be 0. And if it comes back, then you know your cancer's back. For the most part, then that's not all. That's how it was developed. It was never developed as a screening tool. We know colonoscopy, routine colonoscopies decrease colon cancer deaths. Why? Because we're catching it early and we have effective therapy. So if you can catch it early and you can't cure it anyway, who cares? But we can cure colon cancer. So we're catching it before it gets more aggressive. With PSA screening, there's 2 big studies. One showed screening decreased prostate cancer deaths, and the other study showed it didn't. So the American Urologic Association says we should do PSA screening. American Urologic Association makes a lot of money on prostate cancer. The family physician boards do not recommend PSA screening. So it's really interesting. It's something that we do on everybody. We don't even know if we should be doing it. But that's kind of an off topic. But we always got to ask the question, why are we doing it? And the problem is why colonoscopy is decreasing colon cancer death, and PSA, in my opinion, is not. So let's make up a number. Let's say 20 out of 100 people, let's say the incidence of prostate cancer in Springfield is 100. 20 of those men are going to walk in the door and die. Now let's say we can use PSA. Well, instead of 100, now we've found 200 people because we're finding low-risk prostate cancer that people are asymptomatic, but those same 20 still die. Does that make sense? So you have 20 over 100, so 1 in 5 died. Well, with PSA screening, 20 over 200, 1 in 10 died instead of 1 in 5. So we're decreasing cancer mortality. No, we're not. The same 20 are dying. We're just over-diagnosing it. Does that make sense? So we're finding more people with cancer than maybe we really should. So about 75% of men that have a mildly elevated PSA have low-risk prostate cancer. Well, we already know from the European studies, you may not have to treat low-risk prostate cancer. So we're finding something that's natural history may not even hurt you. So it's interesting. What we're not doing, if you look at the spectrum of prostate cancer, I really don't like prostate cancer. Look at the spectrum of prostate cancer. All the money is put into, in the research, is put into low-risk disease. Stop. We don't want that. They're not going to die. What we want to do is figure out how can we make a survival advantage more than 4 months and 60 years. That's all we've done. So all our healthcare dollars for research in prostate cancer, in my opinion, should be on let's prevent those 20 guys from dying. Let's not overdiagnose people who don't need it. Maybe we should redo our screening. The number's 4 nanograms per milliliter. If it's above that, oh my God, you got cancer. You may have cancer. If you're below that, it's fine. How silly are we? So 3.9, oh, you're fine, don't worry about it. And 4.1 is all of a sudden you got bad disease. It's a joke. It's a joke. Guy ejaculates, PSA goes up. I do a rectal exam, PSA goes up. A full bladder, PSA goes up. Urinary tract infection, PSA goes up. So it's not a very good test because it's not prostate cancer specific, it's prostate gland specific. So we have this arbitrary number and we tell us, oh, 3.8, you're fine. Well, I don't know, is 3.8 fine? Is that, in 4.1 you're going to die? So it's a really tough disease to treat. And the problem is in the United States, when we find those low-risk prostate cancers, we're doing a robotic prostatectomy. We're not doing watchful waiting. Not ignore, respect it, and see, are you the guy that if we didn't have PSA and you're 60, and we could look in the future, and if you die at age 85 of a heart attack, but you had prostate cancer, so what? But that same guy who may die of heart attack at age 85, now we're diagnosing him 25 years earlier with a PSA because it's 4.2, and then you get a biopsy. And then, oh my God, you have low-risk prostate cancer. Now he has surgery when he was never going to die of it. Now that guy after surgery, he's impotent. And if people say, oh, the potency rate after a radical, nerve sparing 70, 80%, no, that's not true. Because I see the patients afterwards. Most men after a radical prostatectomy have significant erectile dysfunction. Not all. The older you are, the more likely you will. So the two main complications, and we can talk about this not caused by prostate cancer, is men leaking urine, because the sphincter that holds the urine in place is right next to the prostate. So when you take the prostate out, that sphincter can get injured. The nerves for erections lie just underneath the prostate. Kind of, if you look at the clock, it'd be 5 and 7 o'clock. Those are where the nerves are. And you can do a nerve, we're so silly. You can do a nerve sparing, but who do we do nerve sparing on? Well, they can't have bad cancer because we don't want to get too close to the prostate. So we do nerve sparing on people with low-risk prostate cancer. Well, those are the same people that don't even need surgery. So you do the surgery, post-operatively, men can leak urine. The only way to fix urinary incontinence in men after radical prostatectomy, because it's a sphincter problem, is surgery, to put an artificial sphincter in. So not a big operation, but it's still an operation. We can talk about erection. So if you leak urine after a radical prostatectomy, you either live with it or you do surgery. And it's a quality of life. And I see a lot of those patients I did in Indiana, and I used to look back at the pathology report and kind of say, I don't know if you really need that. Too late. Listen, that was yesterday. You've been cured. Let's try to restore your quality of life. Your quality of life was decreased so you're decreased in order to be cured from your prostate cancer. Now, I could argue maybe some people didn't need to be cured from their prostate cancer, but it's too late after that. It's too late. The doctor, but you had your surgery. You're now cured of your prostate cancer. That was goal number one. Goal number two is let's restore your quality of life like it was. So when you leak urine, when men leak urine, it's usually a sphincter problem and you need surgery. For erections, and this is after radical prostatectomy or just as men get older. 5 ways in the world, only 5, to treat erections. And in clinic, I just get a chalkboard and just write all 5 down. And then we start crossing them out. So, number 1, Viagra, Cialis, Levitra. Take a pill. I don't know which one's better. Susan and I were talking about it. We don't get samples anymore, but I'd call it the weekend party pack. I mean, it'll be a little brown bag, and I'd put in samples of Cialis, Levitra, and Viagra, all of them. So I don't know which one. For some reason, some patients do better with the other one. So I give all 3 and say, try it, and whatever one you like the best, call them, we'll give you a prescription. Easy. Can't do that anymore. So for erections, doesn't matter if it's after a radical prostatectomy or just as guys get older, Viagra, Cialis, Levitra, number 1, first treatment. If it works, it's a home run, we're done. If it doesn't work, then we got to go to the next step. The next step is MUSE, M-U-S-E. This was a medication before Viagra came out, which was, I think, 95 or 97. I was a resident in Indiana, and we had to lock it up because all the nurses were taking the samples. So it was pretty funny. So a lot of residents were taking Viagra. So MUSE, it's a prostaglandin, and it's an intraurethral suppository. It doesn't sound very good, but it's a little pill like a nitroglycerin, and it goes in the tip of the penis in the urethra and gets absorbed. So surrounding the urethra where we urinate are the 2 erectile bodies. So the medication is absorbed through the urethra to the erectile bodies, and you can get an erection. In my experience, if you fail Viagra, Cialis, Levitra, MUSE probably won't work. And then I think the max dose is 750. You learn things over time. So I'd try Viagra, Cialis, Levitra. Patient would come back, and then I was like, all right, let's try MUSE. Here's 500. And then they'd come back, that's 750. And I was like, well, that was a waste of money and time for everybody. I tell them, listen, if the MUSE, Viagra, Cialis doesn't work, odds are MUSE won't. But if we want to try it, let's go to the max dose. Why start here? Because you're going to end up here anyway. So it just saves patients coming in and out of So Viagra, Cialis, Levitra, number 1. That doesn't work, MUSE. But typically, MUSE doesn't work if you fail the other ones, typically. The third one, and this is no specific order, but I do start with the simplest first, the least invasive. We want to restore quality of life. We can do it with a pill. That's a lot better than putting something in your penis. The next one is the vacuum device. So a normal erection is arterial inflow. Like your blood pressure 160, that's arterial inflow into the penis. The erectile bodies expand, and they actually occlude the veins. So blood goes in, can't come out, and then you get your erection. But it's arterial blood flow, arterial. With the vacuum device, it's like on a straw. You're creating a negative, you put the device over your penis and you can pump it up or use a hand thing, and it's actually sucking the air out, so you're creating a vacuum like a straw. That pulls out of your body into the penis venous blood, not arterial blood, venous blood. So it's pulling blood into the penis. then you get this big rubber band and you put it at the base of the penis and it cuts it off. I don't know, cut it off, but it constricts it so the venous blood can't get back into your body. So you get an erection. It's cold because it's venous blood. It's blue. It's all swollen, and it's not very erect. And you got a big rubber band at the base. Yeah, patient satisfaction isn't very good. I tell the patient, I said, listen, if you want to buy it, buy it. Typically, in my experience, it ends up in the top of the closet. Nobody uses it. Doesn't mean you shouldn't try it. I just saying, from a patient satisfaction standpoint, I mean, if I didn't tell you, you don't know. But I tell the patient, listen, you can try it, but most of the time, people don't like it, in my opinion. So, Viagra, Cialis, Levitra, then Muse, the penile prosthesis, which I typically don't have people use, but you could. The next one is, and I would say maybe 80% of men are fine with Viagra, Cialis, Levitra. If you've had a radical prostatectomy, typically those men don't respond because it's a nerve injury from iatrogenic from the doctor. So the oral medication, Muse, the pump, then I would do penile injections. So that same medication, Muse, which is a prostaglandin, where it's a tablet that gets, you put it, insert it into the urethra, the penis, and it gets absorbed. Now we're taking that exact same medication in liquid form and actually injecting it right into the erectile bodies. So right into the penis directly. And this works really, it does work well. And it sounds worse than it is. It really isn't that bad. I have patients come in, if they failed everything else, I mean, usually I say Viagra, Cialis, Levitra, cross off Muse because it doesn't work. Nobody likes the prosthesis, the penile pump at least, cross that off, then you go to the injections. It works very well, and you can, when I started at a low dose, some men can develop what's called priapism, where you get an erection, this is international sign for erection, I guess. You get an erection lasting longer than 4 hours, you gotta go to the emergency room, and typically it's from the injections. So if a patient wants to try the injections, I start at the lowest dose, 0.5 cc's, inject it in the penis and have them wait. And just see how the erection is. If you need more, add more, but you can't take it away. And you don't want them to end up in the emergency room. That's very, very effective. If somebody came in and they had radical prostatectomy and there being no erectile function for years and years, and they usually come in already tried Viagra, Cialis, Levitra, because they would get it from their family doc. I just go straight to the injections because everything else is going to fail. So why try? I mean, we talk about it, but why try? So, the medication, the Muse is really not that good. Vacuum device, nobody really likes. Penile injections work really well. The last is a penile prosthesis. So you're actually it's like an inner tube, and you make an incision in the penis. Again, there's 2 erectile bodies on either side, and then the urethra where you urinate is below. So you put these cylinders actually inside the erectile bodies, and then there's a pump in the scrotum, and you can't tell when it's flaccid. You can't tell if a guy has a penile prosthesis or not. You can't. When you want an erection, you pump up the pump in the scrotum, that drives fluid into the cylinders, and you get an erection. I mean, you can't compress fluid, so this is as hard as hard. So it's a really good quality erection for the patient and the partner. For the erection to go away, typically a guy ejaculates or has an orgasm, and then the nerves relax the arterial inflow, and then the erection goes away. Well, this doesn't work this way. You pump it up, it stays up to you. There's a little button on the side of the pump, and that drains the fluid. And I had a guy when I was in Indy, he called my secretary, Trish, she's my age, we were really good friends, and this poor guy had it pumped up for 3 days. I'm like, hit the button. And he's like, he couldn't find the button. So I said, come on into it was funny. He's like, 3 days? And I had another guy, I don't know what happened here, but anyway, so he came in, I hit the button, and I probably didn't do a very good job on showing him where the button is. Now they have actually like little models of the pump. And it's the same thing for the sphincter. Guys with the sphincter, you pump it to open up the sphincter and urinate. But anyway, this guy had one, and he broke his prosthesis. And I was like, usually it's don't ask, don't tell policy in the urology clinic. But I kind of was like, what happened? He's like, I fell out of a tree. And I'm like, Man saved from death from falling on penis. I don't know what he did, but I don't know what he was doing up there. But anyway, we go to all these links to restore quality of life. And, I do a lot of cancer surgery. I do a lot of this surgery. I'm a urologic oncologist, but we do general urology. It's a fun specialty because we see women. We don't see kids anymore, children, but, we do kidney stones. We do all this other stuff. But, I've learned sometimes we do too much. And if it's either you have cancer or you don't. That's how I look at every patient. If you don't have cancer, well, nothing's going to kill you. What do you want to do? If you have a little kidney stone, well, if it's not bothering you, do we really need to take you to the operating room to take it out? If it's not bothering you? We do a lot of things I'm not sure we really need to. And a great question to ask a doctor, in my opinion, is, well, what happened if we didn't do this? What happened if we just watched it? It's a really good question. Probably nothing would happen. So when it comes to cancer and it's life or death, the treating physician and the patient and family have to be on the same page to say, we are going to hurt you, to fix you, to cure you. And we may not cure you, but we're going to try. But you're going to have permanent side effects from it. But is it worth it? That's my concern a little bit in the United States with prostate cancer. Because I'm not really sure, and I think I would love to have a video consent. And patients, sometimes they try to get sneaky and record. You record anything I say. I have no problem with that. Meaning, are we giving patients true informed consent? And how can you make a decision if you don't know what's behind door A, B, or C? That's not fair. So for prostate cancer, I have a slide, I guess we could do it later, but the way and this is not Steve Beck, this is worldwide. You have low, intermediate, high-risk prostate cancer. Low, remember Dr. Gleason? Gleason grade is 6, PSA less than 10, normal rectal. That's low-risk prostate cancer anywhere in the world. Intermediate risk, Gleason 7, PSA between 10 and 20, or a little bit of a nodule. If somebody's PSA is 5, but their Gleason is 7, you're already intermediate risk. Then you have high risk, Gleason 8. The big thing is the Gleason 8 or really high PSA. Then I say, okay, where are you, sir? Where are you as an individual? He says, okay, you're intermediate, based on if your PSA is between 10 and 20 or your Gleason is 7. You're intermediate. That's not my opinion. That's fact. But we know, how can we treat prostate cancer? Well, we can do watchful waiting. Remember, that's an option. We can radiate, we can do surgery, or we can do hormonal therapy. Well, that's it. That's it. If you're intermediate risk, watchful waiting is not a good option. You can do it, but it's not a good option. So you got to have all the doors. So, okay, which door do I want to choose? And I would say you can choose observation, but probably not a very good one. Not because of me, because the pathology of the cancer dictates what happens. And if you have intermediate risk prostate cancer, watching it may not be a good thing because that may be the type of cancer where it could hurt you down the road if you don't treat it. Does that make sense? So when I say, well, watchful waiting, whatever treatment, it's based on the tumor. Now, if you're Gleason 8 and high-risk disease, I would say, listen, surgery is probably not the best thing. You need hormonal therapy and radiation because they did that trial, and hormonal therapy and radiation for poor-risk disease is better than anything else. Now, is surgery an option? Yeah, but not a good one for that particular disease. It's interesting. They did a study, because I gave a talk on prostate cancer and how urologists aren't very good at it, in my opinion, in the United States. We're good at the surgery, but are we good at selecting the patient? And they had a study and looked at another one looking at what if we did nothing versus surgery or radiation, some form of intervention. And I want to make sure I say this clearly. So we have low risk, intermediate, and high risk prostate cancer. When somebody walks in the door, not metastatic disease where it's already spread. Everything looks like it's confined to your prostate. Your bone scan's negative, your CAT scan's negative. So by all means, every cancer cell that we can find or detect, nothing is elsewhere in the body except in your prostate. Theoretically, if every prostate cancer cell is in your prostate, and we remove your prostate, it should be cured, right? I mean, if all the x-rays are normal and we take out the cancer, the cure rate should be 100% for any cancer. The problem is it's not. Why? Because some patients already have one cancer cell sitting in a lymph node or sitting in their lung or their bone, and we don't know that. Every x-ray, we don't know who does or who doesn't. You take out the prostate, then 3 years later, that one cell is now 100 billion cells, and your PSA is going up. Well, we didn't know that was going to happen. So what we do is when you take the prostate out, you look at the final pathology, and that is a predictor of what's your chance of your PSAs coming back. So if you have seminal vesicle invasion or high-grade disease, I would say, listen, we've done these studies, we followed 1,000 men, and we know 70% had their PSA come back if you're really high risk. Well, 30 didn't. Now, we don't know if you're in the 30 or the 70. We just know those are the odds. You may make it, so we have to follow everybody. So they did this study, so we have low, intermediate, and high risk. If we took out low-risk prostate cancer for this half of the group, and we did nothing on this half, no difference in survival. So, meaning the cancer is so indolent in the appropriately selected patient is so indolent it doesn't hurt you anyway. So if there's no difference in survival for the most part, and people could argue against, you can always find something to, but for low-risk disease, surgery versus do nothing, no difference. Why? And this is important because the cancer is indolent. It's slow growing, not going to hurt you for the most part. I mean, high-risk disease. This group, we did surgery and radiation. This group, you have high-risk cancer. We didn't do anything. Maybe treat when it relapses, but basically didn't do anything for curative intent. There really wasn't a huge difference. Well, why? That doesn't make any sense. If the cancer is so bad, and even though all the x-rays are normal, if that cancer is already spread microscopically, and we take out your prostate, taking out your prostate didn't do any good. Does that make sense? So if it's high-risk disease and you already have something up here, but we don't know it, let's say everybody in this room has high-risk prostate cancer, and in the front row, you really don't have anything else anywhere in your body, but everybody else has microscopic disease. We take out your prostate, you're still going to recur because it's already spread. Over here, we didn't take out your prostate, but it didn't matter because it's already spread. Does that make sense? So so for high-risk cancer, we're not curing patients. They're still dying with the therapy, with the curative therapy we have. So we need to focus on that. For low-risk prostate cancer, maybe we shouldn't do anything. And it's the intermediate group that actually surgery and radiation actually has an impact. It doesn't have an impact really for low-risk disease. Not saying, making generalizations, but for low-risk disease, one could argue therapy doesn't have a huge impact because it's slow growing. For the high bad disease, you could argue therapy doesn't have an impact because it's already spread. We're just not smart enough to figure out which person it's spread in and which one it hasn't. I mean, if we knew on every single patient who has microscopic spread, we would never operate on them, ever. I took a kidney out a couple days ago. Well, I knew that lady had disease elsewhere. I shouldn't take it out because the local therapy is not going to help if it's already spread. It's a fundamental thing of oncology. If it's already spread, taking the local organ out, too late. The problem is we don't know, in the high-risk group, we don't know if it's already spread, but it's so high risk, probably everybody has. That's why therapy doesn't have, the existing therapy we have doesn't have a huge impact on survival. For the intermediate risk group, Gleason 7, surgery had a big impact because if it hasn't spread and you take it out, you're cured. So this group, we cured a lot of people with surgery. If we did nothing, ultimately, even if it hadn't spread, it will if you watch it long enough. So that patient would die. So with Gleason 7 disease, we're catching it where it's still, for the most part, confined to the prostate. So if you get it out, you can cure that patient. Where if you just do watchful waiting and do nothing, it could spread, and the patient would have metastatic disease when they otherwise would have been cured. Does that make sense? For the high-risk group, it's too late. It's already spread. So it's the intermediate group, in my opinion, that we have the biggest impact on survival. But again, what's the cost? What's the cost? And not just healthcare dollars, but for quality of life in men, and it's impotence and incontinence. So that's prostate cancer in a nutshell. And honestly, and we were talking about this a little earlier, really since, I think it was Hughes and Hodges, I think, 1945 or 40, won the Nobel Science Prize. And what did they do? These two guys, they took out, can't remember what dog model, I think the Doberman Pinscher or something, or the Dalmatian had prostate cancer. They cut out the testicles. They cut the testicles out, and your testosterone goes to zero. And that slows the growth of prostate cancer. We don't know if we give somebody testosterone, if that will increase the risk of prostate cancer or make it more aggressive. But we know if we take prostate cancer, or if we take testosterone away, the prostate cancer will slow down, because the cancer feeds on testosterone. That's why I think the eunuchs in Egypt, years and years, or 100 years, whenever it was, never got prostate cancer because their testicles were removed. So that was done, 1945 or whenever it was. We've got all these new therapies, but from there to where we are now is about a 4 to 6 month survival advantage. So not a big difference. Testosterone is another issue for men as they get older. You have a decreased testosterone. Susan, I'll be finished in a second. You get decreased testosterone. The problem I have with testosterone replacement is the range is huge. The normal range, I don't know who decided what normal was, but normal range for testosterone is between 300 and 1,200. Or 300 and 1,000, depending on the lab. So if a guy walks in and says, well, I have no libido, I'm tired, I have no energy, well, I'm tired too. But so we don't know if is that really you, or is it because you're testosterone? And people, well, if it comes back 500, well, the doctor would say, well, it's normal. Well, hang on. How do we know that? Your level may be 700, and it comes back 400, you're low. But it's normal by definition of the lab. So it really confuses me. And I asked other doctors, I said, well, I got a guy and his testosterone's 400 or 500. Would you replace the testosterone? And they said, no, it's normal. I'm like, well, how do we know it's normal? Because we don't have the baseline. So it's really tricky for me. But again, if it's not cancer, I don't care. If you come in and somebody's testosterone level is 500, but they have symptoms of a low T, or low testosterone, why not just give some testosterone and see what happens? I'm not saying here's a bunch of testosterone running around like Superman and I'll see you in a year. Let's try a little bit and come back in a month and see if you're better or not. And maybe go more by symptomatology versus a number. So I don't know if people do that or not. I don't know, but it seems like something to try, and there's no downside. If you come in and you're better, it's a home run. If you come in and you're not, well, we didn't do anything. Same with BPH for men with big prostate cancers. I don't need all these tests. I'm going to give you a pill, Flomax or Rapaflo. They have all these different names. So basically, Flomax is the best one, or ones like it. It's an alpha blocker, and it just relaxes the prostate. The prostate has a capsule around it, like a rind of an orange. And people think it's a big prostate. It really isn't. I mean, your prostate can grow outwards. Well, that's okay. The problem is it's so tight it can constrict the urethra, so it's hard to void. You got to strain because you got to increase your bladder pressure to get past that prostate. Well, Flomax relaxes the receptors. It blocks the muscle receptors on the capsule, and it relaxes the prostate so you can void it. And years ago, they had Cardura and all these other medications, and we had to be careful because guys would get dizzy. That's why we say take it at night, because those same receptors are on your veins, or near your veins. So if somebody stood up, they could get lightheaded because the blood rushes to their feet. So we'd say take it at night. So for BPH, it's easy. Here's a pill, Flomax. It takes about 2 weeks to work. If it works, it's a home run, we're done. There's another one called Proscar, which actually blocks the conversion of testosterone to something called DHT in the prostate. So it actually does shrink the prostate, but it takes 3 to 6 months to work. Important from a cancer standpoint, Proscar or Avodart decreases your PSA by 50%. So if a guy walks in the door and his PSA is 3, Oh, great, it's normal. Remember, 4 is a cutoff number. Well, if you're on that medication, your PSA is really 6. And they did a study at the VA years ago. They gave half the guy a placebo and half of them Proscar, and there was no difference. So, but we still give it. The only caveat of that is if patients have a big prostate, like a large volume prostate, Proscar can help with that. So I know I kind of jumped around a little bit. I get on my side topics, but I hope this was informative. Susan, I don't know if we want to do questions or typically if somebody has, most important thing with cancer is it local or is it systemic? Meaning, is it all confined to the organ or is it already spread? If somebody has radiation or surgery for prostate cancer, the assumption is it's all confined and your PSA goes to 0. If your PSA recurs after surgery or radiation, starts going up, typical treatment would be hormonal therapy. 1945, remember they cut the testicles out. Now we give Lupron injections or other type of injections. If that goes down, so your PSA should go down after that. If it starts going back up, and you can try something called Casodex, which is also an anti-androgen. Oh, okay, that blocks the testosterone as well. But if somebody has PSA rising after being on hormonal therapy, it's called hormone refractory prostate cancer. And typically it's chemotherapy, like Taxol, doxycycline. I will say, I've had, for prostate cancer, if somebody takes out your prostate and your PSA comes back, that's not necessarily a life-threatening issue. If it comes back within 2 years or really starts doubling, that's bad. But I've had people come in on hormonal therapy, and I said, well, why'd you start it? And it was like, well, the doctor told me my PSA was 5 years after surgery. I was like, so what? Let's stop it. Because it could be 5 for years, then 6, then 7. It takes me, in some patients, it takes a long time for that PSA to get high, so why give the hormonal therapy until you need at some threshold? That's what I do. You know, they've got to study bone scans and CT scans are almost universally negative if your PSA is below 10 or 20. It's always negative. So we're kind of treating a number. And hormonal therapy has a lot of side effects. So I can talk after about that, but there is therapy after that. And I didn't want to say that low-risk prostate cancer can't be harmful. It can. Just like anything, you think it's low risk, and some people can get metastatic disease. But all I'm saying is I think we need to really look at sometimes what physicians are doing and why are we doing it. If we're doing them for medical, legal reasons, that's not good enough. That's not good enough. And I've done quite a few cases where they want me to review the records, and a lot of it is misdiagnosis. It is, but if you have a good rapport with the patient and tell them this is what we're doing, we're not going to ignore it, we're going to respect it, and these are the pros and cons for whatever. Remember, we all have these treatment options, but I got to tell you all of them, and as long as you have that rapport, I just think that we really need to ask a very fundamental question, why? Or what happens if we do nothing?
So-called low-risk cancer gravitates to high risk.
Correct. The problem is this, and good question. The problem is you have your prostate and we do biopsies. Well, they're random. They're like throwing darts at a dartboard. It really is. I do 6. Why? Because all the studies were done on sextant, 6 biopsies. Now some people do 10, 20, 15. So if somebody has low-risk prostate cancer, meaning Gleason 6, let's say 1 in 10 cores, theoretically, he could have worse disease than that. We just don't know it, right? Because we didn't hit it with the biopsy. So if somebody, again, we don't ignore it, we respect it. So if I had somebody with low-risk prostate cancer, depending on some other factors, I would say, why don't you come back in 6 months or a year, and this is a protocol from Hopkins, and repeat a biopsy. Because I want to get more samples to make sure we're not missing a Gleason 7. That would push you into, you shouldn't do watchful waiting, right? And if you do another biopsy in 6 months and it's negative, I had a patient say, well, my cancer went away. No, it didn't. It's so small, we just didn't hit it again. And just because you have a negative biopsy doesn't mean you don't have cancer, right? It just means you didn't hit it. So there's a lot of false positives and false negatives. But that's the concern. If we're going to treat or manage low-risk prostate cancer by watching it, what we want to do is try to identify the guys that truly have low-risk disease, but identify also the ones that have maybe a Gleason 7 and we didn't know it, and those are the ones where you don't want to do watchful waiting. I'm just saying I think a lot of the times patients can do watchful waiting and perhaps aren't given the opportunity. I don't know what I would do. I don't know. You walk in the door, there's cancer. But I tell patients, well, go home and come back and think about it. Prostate cancer is not going to kill you in a month. Nothing's going to change in a month. If we did a biopsy on you today and you had cancer, well, you had it 4 months ago. You had it 6 months ago. So sit back and kind of really think about what you want to do before you, because everybody's scared. You jump into something, and the worst thing from a surgeon standpoint, I think, is having a patient say, boy, I wish I never had that done. Well, guess what? Too late. Too late. And that's when we got to go down the road of sphincters and penile prosthesis and all this to kind of fix the damage we did. That's the thing. 3.8 is no different from 4.2. There's no difference. That's I'm kind of making fun of urology in the United States. They drew a line, and it was 4. And a patient comes in, it's 3.8, great, I don't have cancer. No. There's no difference between 3, but we have to draw a line in sand somewhere. And if it's 4.2, we would do a biopsy. And if we do a biopsy and it comes back negative, you could still have cancer, right? Because it's just random, you're just like throwing darts. And so the number's good to follow, but we can't hold everything to it. And a PSA of 3.8 for me, I'm 44, almost 45, that'd be a lot more concerning than somebody who's twice my age. Because we know they used to have age-specific PSA where the older you, it was more fluid. Instead of saying, okay, every man in here, it's PSA of 4 for my 4-year-old son or for my 80-year-old father. Well, that's crazy. So if you got older, your PSA could be higher, right? So a normal PSA in a 70 to 80-year-old man was 6.5 or lower. So they use this age-specific to try to cut down on the number of biopsies for men. But that's kind of out the window now for some reason.